Hello, my name is Agatha Gichana, and this is the Velam Podcast, your go-to place for insights on policy developments, socioeconomic trends, and all matters affecting industry and society. Now, for this particular episode, we're going to be talking about the human papillomavirus, or popularly known as HPV. Now, the unique thing about HPV is some of its strains are actually known to cause the second most deadliest form of cancer, that is cervical cancer. And there is data that shows that annually, there are about 3,500 young women under the age of 35 years who die from this form of cervical cancer. But hold that thought. Some of the people that are going to be joining me today to unpack this important and timely topic are with me today, and I'll let them introduce themselves, all they starting from my right, please. Dr. go ahead.
Thank you for having me to discuss this important topic of public health interest. My name is Dr. Benjamin Odongo Eli. I'm a gynecologic oncologist and also the chairman of the Department of Obstetrics and Gynecology at Kenyatta University.
Good afternoon. My name is Savai Pamela. I'm a cervical cancer survivor. I'm a patient navigator. I am a health advocate on cervical cancer, raising awareness and sensitization. Thank you.
Good afternoon, everyone. Again, thank you too for inviting me take part in this session. I'm Dr. Charles Wahome. I'm an anatomical pathologist, and I also serve as a chief consultant pathologist at Cerba Lancet Kenya.
Thank you. I think when people think about the human papillomavirus, it's a big word. And I know quite recently there's a lot of social media sensitization on the HPV virus. But I'd like for us to, first of all, contextualize it. And this is why I came to you, Pamela. If you could just explain to us, how did it feel like the first time being diagnosed with cervical cancer?
Everyone knows at the mention of cancer, the first thing your mind goes to is death. Because it's been well known that cancer is a disease that has no cure. But when I was diagnosed with cervical cancer, I really thank God for the doctors that I was with. First, I started with Dr. Maranga, who did the diagnosis. And the first thing he told me was that, Pamela, you shouldn't worry about this, because cervical cancer, when captured early, is one of the cancers that can be treated and you get healed. And after that, hysterectomy was done to me by Dr. Igogo. And when the part that was affected was removed, it went for bio also. And then it was found out that the cancer had been captured. So my fears came down. But at first, I was devastated. I saw death. I was so scared. I saw myself dying. I didn't have any hopes of surviving.
I mean, I can only imagine when most people think about cancer, they immediately think about the dire effects of being diagnosed with such a disease. But when did the doctor catch it? Was it during a routine checkup, or did something happen that triggered you to actually go for a medical examination?
I was a healthy woman, no signs or any symptoms of any disease, no discharge, no bleeding. So it was during the January is normally the Cervical Cancer Awareness Month. So I saw posters. There's this group, Women for Cancer. They were having an activity of screening. So it was one Sunday, and I think it was the last day of the activity. I just told myself, I dressed up to go to church actually. That was 2019 in January. Then I told myself, why can't I just go for this screening? So I went. And the screening saved my life. When I was screened is when they find out that there was something which was not okay with me. And I was sent to go for pap smear, then colposcopy, and then that's when I did biopsy, and it confirmed that I had cervical cancer stage 1A.
Oh, so that was at stage 1. The doctor caught it quite early on.
Yes.
And how was the testing process for you? The pap smear that you did?
The testing process was okay, and I really thank God for Women for Cancer, because they helped me financially, because I think if I could have gone to a I started going to a public facility, but the traffic there was so high When I went in, cervical cancer came again for me. They looked for me through the patient navigator, and they got me, and is when they took me to Dr. Maranga at the Janis Hospital. And within less than 2 months, all the tests had been completed, and that's when I went for my surgery. I started my test in 29th January, and 29th April that same year, I had my hysterectomy, my surgery done.
And you're declared cancer-free after the surgery.
Yeah. I'm now 6 years now. Survivorship.
I think what I'm getting from Pamela, from your story, is that there were no obvious signs. You were not in pain at all. It was just January. It was Cervical Cancer Awareness Month. You took the initiative to go for the test, which brings me to Dr. Odongo. Help us exactly to define what is HPV. Are there any signs that women should be look out for, or should people, and women in particular, like Pamela did, just go for routine checkups?
Thank you. I will try to make it as simple as possible. HPV stands for human papilloma virus. It is one of the viruses that are known to affect the reproductive tract. It's good to note that there are over 100 subtypes of human papilloma virus, but only a few of them are associated with the development of cancer. To be specific, type 16 and type 18 are responsible for more than 70% of cervical cancer. We also have other human papilloma viruses which are low risk. In type, they are not really responsible for cancer. Others are responsible for just causing warts. And so the reason why we say they are high risk, because around 9 types actually have the ability to invade the cell of the cervix. And for those who may not know where the cervix is the lower part of the uterus. It's around 3 centimeters or so, and it has a lining. And those lining has some cells which are susceptible to infection by the human papilloma virus. So the high-risk type have the ability to take over the host cell in terms of the reproduction, the DNA sequencing and all that, and alters it to make it cancerous. So usually there are no signs that the women report. But however, when the disease is advancing, we have advanced stages of disease, then you start having complaints. And the common complaints are issues to do with abnormal vaginal discharge, which does not respond to conventional antibiotics. And quite a number of women who come under our care, they have gone through a lot of treatments for abnormal vaginal discharge, which is usually watery. Occasionally it becomes foul smelling. It's also important to note that they start experiencing abnormal bleeding. Could be intermenstrual bleeding, but the commonest is what we call contact bleeding. Contact bleeding means bleeding after sexual contact, whereby they have what we call the postcoital bleeding. In advanced stages, they start experiencing pain, also low abdominal pain, and symptoms related to advanced disease in terms of pain in the legs, swelling, and also the flank pains, because sometimes the disease blocks the passage of urine from the kidney to the bladder. It's what we mainly call the terrible triad of advanced cervical cancer. Is usually we call it sciatic pain. Then we have got deep venous thrombosis, means that there are blood clots in the legs with swelling, and right flank pains. It's called the terrible triad of advanced cervical cancer.
Dr. Odongo, you point quite the gory picture when it comes to the advanced stage of cervical cancer. But at what point does it morph from just an innocent infection, you have maybe genital warts, and then all the way to the advanced stages that you talked about? Are there particular stages where one can know that now I'm in the advanced stage? Because you mentioned that there are no particular signs.
Yeah, and that's the importance of screening. And that's why the major reason why we are really talking about this subject, because it takes up to 20 years, in some cases up to 30 years from infection to development of disease. It's a very slow process. But just to kind of qualify this further, this disease tends to be more accelerated in any situations whereby you have got immunosuppression, mainly because based on our immune status, most women clear HPV infection within the first 1 or 2 years. The problem is usually persistence of the HPV. And the disease can persist because of one reason or another. One is being those with immunosuppression. For example, we are seeing cervical cancer being 4 to 5 times more common in women with immunosuppression because of HIV, or those who have another malignant condition, or those who are undergoing organ transplant, just because of the fact that they are immunocompromised. But those are a smaller proportion of our population. Still, majority of population could be immunocompetent, and the disease takes a very long time from infection to development of cancer. At the risk of maybe taking over what the pathologists may want to mention, but it progresses from pre-malignant phase. Pre-malignant phase means you have got changes that are happening on the cervix, but they are not cancer yet, in that they are not yet reached that level of invasion. And pre-malignant phase is divided mainly into 3, which is known as CIN. CIN means cervical intraepithelial neoplasia. It just means that the changes are confined to the cervix, whereby you've got, if the lower third of the lining is CIN1, middle third CIN2, then CIN3, then after that is when now you develop invasive cancer. And
in those first stages, can surgery be made or you just cut out?
Yeah, I think I can break down that further, because if you screen and you find that, let's say, you've done a pap smear, and the pap smear is suggesting that one has a high-grade intraepithelial lesion. What I mean is, pap smear looks at the cells, the appearance of the cells. And once the cells appear that they are heading towards cancer, then you're supposed to do what we call colposcopy. Colposcopy means you examine the cervix under magnification with a special kind of a camera that magnifies the cervix. You apply some staining like vinegar, and from there you are supposed to do what we call a biopsy. Biopsy means you take something small from it. Then that is when the pathologist looks at it and tells you whether you are dealing with CIN1, CIN2, or CIN3. CIN1 usually regresses up to 57% of the time. So usually there is no recommended intervention for CIN1. But once you have got CIN2 and 3, something should be done, depending on fertility desires, age, immunocompromise, amongst others. So for CIN2 and 3, you can either do 2 main pathways, either we call ablation. Ablation means with the kind of destruction of the cells, either by freezing them, we call that cryotherapy, or you can do thermocoagulation, that's we call the ablation or ablative procedures, or you can do excision procedures. Where excision procedures, you can either use a loop of wire that has electric current, we call that loop electrosurgical excision procedure, or you can actually take them to theater and use a knife, we call that one cold knife conization. And each of these have advantages because, for example, if you do cryo, the ablation techniques, I will not have a tissue to submit to the pathologist to really confirm it is CIN1 or CIN2 or CIN3. That if I do an excision procedure, then I'll be in a position to submit something to the pathologist to confirm actually what we removed is the stage of we are thinking it is.
Before we delve into the treatment methods, I'd like to go to Dr. Wahome. What I'm hearing is women. So help us understand, is HPV only prevalent among women? Is this something that just affects women, or is this something that both sexes can be affected with?
HPV infects both men and women. We tend to focus a lot on women because it's women who get cervical cancer. But it's important to note that HPV does not only cause cervical cancer, it does cause other cancers that occur in what we'd call the anogenital region, so the perineum basically. So it can cause vaginal. The vagina, just for simplicity, is a canal from the genitalia that's visible up to the cervix. It can also cause cancer of the vagina, which is a genitalia that is visible. It also does cause anal cancer. And it has also been known, and it does cause cancer arising in what we would call the upper digestive airway system or aerodigestive system. So going back to your question, HPV is very, very, very common. Dr. Dongo has pointed out that the probability risk of getting HPV after sexual debut is about 50 to 80%, that it is transmitted through sexual contact and skin-to-skin contact. Again, that one already states that it does afflict both men and women. Having said that, it is important that we are clear that having HPV infection does not equate to promiscuity. The lifetime probability risk of anyone, a man or a woman, ever getting HPV is anywhere between 85 to 91% based on the gender. And having stated that, again, it is important that we are clear that, again, for a virus that is so common, majority of the infections are transient and they're just cleared by the body's immunity, as had previously been stated. Yes.
Then why is it the case that the effects of these particular two strains that you talked about have such adverse effects to men? So let's say a man gets HPV, would there be any adverse effects to them?
Oh, sorry, and I forgot to mention that HPV also causes penile cancer or penis cancer. Coming back to that, the issue with HPV is not just an infection. Remember, majority of the infections, they're transient, they'll be asymptomatic, they'll be cleared by the body. And, it's such that 90% clear 2 years from the time they're infected. The issue is when the infection persists in the body. That persistent infection, and there is different definitions of what persistent infection is, but the commonest one that people will often use is infection being identified today, and then at a different time point, which is often 6 months to a year, the infection is still identified. So the persistent infection is what increases the risk of getting cancer. So now, at that point when the disease has become persistent, there's still no symptoms. You still don't know whether the disease is there. Sometimes there might not even be any cellular abnormalities that can be identified under the microscopy. And of course, if there are no cellular abnormalities that are identified under microscopy, it means that even when a doctor is doing a pelvic examination of the cervix, they'll still not see any issue. That's where now the screening comes in. So now what happens is that, remember, this virus, what it is trying to do is just reproduce, replicate, survive. And what often happens, and that has been pointed out, is that the virus will then hijack the cellular mechanisms that help cells replicate. So think of it this way. The HPV would be like a hijacker who wants to travel to Europe, and they hijack a plane that is going, say, to Mombasa, and they take over, they commandeer the process. Now what happens is, as much as there were controls, and one of the controls was the pilot has been eliminated by the hijacker, and then the hijacker has also negated the role of the air traffic controller. So now what happens is that the plane will then now be diverted, and even if it loses the fuel and crashes, which is what now would equate to conversion into the precancerous. So The ultimate aim of the HPV is not to cause cancer. It's just that the cancer occurs as a collateral damage by the HPV taking over the cell's mechanisms and getting rid of the checks and points that ensure that where a cell has damaged DNA, it does not continue down reproducing. At the end of the day, what causes tumor is the changes in the DNA sequences, the cells, which we call mutations. Once those mutations come, the cell then now starts growing abnormally, it becomes invasive, and we end up with a disease called cancer.
And this hijacking process, just to use your analogy, can take as long as Dr. Dongo, you mentioned 30 years. So it's a constant state of the body trying to suppress that virus. And in the event that it's not able to suppress that virus, it gets to a moment where it takes over. And that is the point that you mentioned, that it could lead to cancer.
So a couple of things to separate. There's a process of from when the persistent infection has taken root up to when we have cancer manifesting. Can think of it as a continuum. So the persistence, once it becomes persistent, means that it has now integrated into the cells. Some of the cells will be taken care of by the body's immunity, but there will be some changes that the body cannot take care of. But what is critical and what is important, and this is what I want to emphasize on, is that opportunity that we have from when the persistence occurs to when we have fully fledged cancer. It can be anywhere from 20 to even 30 years. And that's a huge window.
It's a huge window.
Where we can have our ladies undergo the screening to identify whether they have the precancerous, the early stages in that continuum, where intervention can actually deliver full cure.
I'd like for you to hold that thought on intervention methods. And I was looking at some data, and they were talking about women under the age of 35,000, about 35,000 deaths annually. So is there a particular reason is there a particular region where the prevalence, the burden of cervical cancer is particularly high in East Africa or in Kenya? And there may be counties where you find a lot of spikes in cervical cancer.
Cervical cancer is one of those diseases that highlights the global inequities in terms of resource distribution. The highest burden of cervical cancer is in our part of the world, sub-Saharan Africa and other low and low-medium income countries. Yeah, that's where the burden is. The thing is, HPV is present all over the world. Cervical cancer is present all over the world. But what has happened in the rest of the world is that they have had national wide programs being implemented to screen for cervical cancer. 2, they also have resources that allow them, once the pre-cancer or cancer is identified, to implement effective management strategies, whether it's curative or rehabilitative. We are looking at palliative care. And as a result of that, we tend to find that in that part of the world, there's low incidence, there's low mortality. And just to put everything into perspective, when we combine the world data, global prevalence, and the incidence and the mortality, the cervical cancer does not rank as high as it does in our part of the world. It's like around the 8th most common in terms of incidence and the 9th in terms of deaths. But you come to our part of the world, it's number 2 in terms of incidence when you combine all age groups, and it's number 1 in terms of the cause of death. The unfortunate for statistics, and they say that 9 out of every new cases and deaths being identified are occurring in our part of the world. That's a stark.
I think that's quite
numbers.
sad.
Yeah.
And it's also reflective of, like you mentioned, the lack of resources, the lack of preventative measures that would have easily capped the spread of cervical cancer, especially in this part of our world. And I'd like for us to now segue into the intervention methods, the treatment methods. And I'd like to ask you, Pamela, when you were diagnosed with cervical cancer, did you have a session where your gyna explained to you that this is the stage at which the cervical cancer is at, and these are the options that are available for you? And what informed your decision, like you mentioned, to go for surgery?
Yes, after the biopsy results came, my doctor at Janice Hospital, Dr. Maranga, sat with me and he told me that the best option for me was hysterectomy, having surgery for the affected part to be removed.
For the sake of our audiences, what is a hysterectomy? What does that process involve?
Well, hysterectomy is removal of the uterus. There are different classes of hysterectomy depending on the stage of disease and the level of spread of disease.
I'd imagine that is quite an advanced method of treatment. Were you, when you were told that that is the option, that is the most viable option, I mean, how did you feel about that, losing your uterus?
I tell you, I was so scared of having cancer. I even told Dr. Maranga, if there's anything related to my reproduction system, just get it out, everything. I did. That is how it was. So he told me it hadn't spread. It was just the cervical area, and I think just a few millimeters. It had not really gone. And then I had kids. I wasn't intending to have any kids, so it was well with me to have my uterus removed. And the fear that maybe having the uterus, it might come also. Yeah. So I was very comfortable with the surgery, and he explained to me well.
The option of having a hysterectomy or removal of a uterus, because you had already born children, you're at the age of your life where you felt like even if you were to lose your uterus, it would still be okay.
But even if I didn't have children and I have my life, I was better with that. Yeah.
I think this is quite fascinating for me because for a lot of people, especially in our social cultural environment, a woman's fertility is very, very important. And I don't know if in your experience, Dr. Odongo, when you're breaking down the treatment options for people who have been diagnosed with cervical cancer or advanced stages of HPV infection, what are some of the factors that you consider, and what, when you're advising a patient on the viable treatment option?
The treatment options are guided by, of course, patient autonomy and stage, because the final decision actually has to be left to the patient to make us to the kind of intervention that they'll take. It's required of us to give all the available options depending on what level of reproductive career the woman is at. And I may just give a few examples. If you allow me, I may just go stage by stage. Generally we have got stage 1 to 4, and out of this we have got even other sub-stages. So I may give an example of a stage 1 disease. Stage 1 has two subdivisions. Stage 1A means a microscopic disease. You cannot see it with a naked eye. It's the pathologist will actually tell you that it's a stage 1A based on the level of invasion. And stage 1A also has stage 1A1, 1A2. This is a very early disease. And actually, excision means cutting off the cervix can be sufficient to take care of that stage. But when you go to stage 1B, means that if you examine the cervix, you can literally see there's a growth there or a tumor. And 1B is also subdivided into 1B, 1 less than 2 centimeters, 1B2, 2 to 4 centimeters, and 1B3, more than 4 centimeters. So these are women who may require a more radical approach in surgery, not just a simple hysterectomy. For example, if it's a woman who has achieved a desired family size, you can do what we call a radical hysterectomy. Means you remove the uterus plus its supports, a little bit of the vagina, and you also look at the lymph nodes. However, if it's a woman who may still require to preserve fertility, you may do what we call a radical trachelectomy. Trachelectomy means removing the lower part of the uterus together with the lymph nodes. But in this case, once you do that, you're also compromising the ability of the uterus to carry a pregnancy. So
but there's still that option.
Yeah, there is, but you have to put a stitch on the lower part of the uterus to prevent preterm labor, and that. So there's an option for that. However, if you have got advanced disease that is not amenable to surgery, because not all of them are amenable to surgery, then in that case, the women undergo what we call concurrent chemoradiation. By concurrent, I mean you give chemotherapy and also you give radiation therapy with intent to cure.
I think listening into the treatment options, none of them would be an easy choice for any person, truth be said. And I think I'd like for us to even go back to now the preventative measures, the screening. Kindly advise us, Dr. Wahome. When should people start the screening process? What are the options available to them? Where can they go for screening?
In terms of the screening, again, the patient factors matter. So what I'll do is, let me first talk about the programmatic screening as per the Ministry of Health guidelines. So for Kenya, the Ministry of Health programmatic guidelines, meaning meant for the entire population, is we're targeting women between the ages of 25 years and 49 years. However, when you look at practice, the rest of the world, and also now outside the programmatic, the eligible women range also expands a bit from 21 years to 65 years. Now, that's not cast in stone, as Dr. Odongo will point out, because again, we also have to evaluate patient risk factors and sometimes continue the screening beyond the 65 years and even sometimes even commence below the 21. So now, what the guidelines have tended to do, the programmatic guidelines like the MOH one, is that because this is an infection, and being infection, because we know that people who have anything that may impair their immunity will have a higher risk of persistent disease because they're unable to clear the disease. Our guidelines have two scenarios when it comes to screening. So scenario one is for the general population who are HIV uninfected or don't know their HIV status. The recommendation is to start at the age of 25 years, going up to the age of 49 years. Now, for the HIV positive population, we tend to start a bit earlier. And the interval of screening also tends to be a bit shorter. So now, to avoid confusing, I'll stratify those two populations. There are three modes of screening available. The most preferred, what is recommended by our Ministry of Health, as well as the WHO, is a human papillomavirus PCR testing. However, when it comes to the HPV, for the general HIV negative population, the recommendation is to start at the age of 30 years. And for anyone who gets a negative result, meaning that no HPV has been detected, they screen after a 5-year interval. For the HIV positive population, those who know their status, recommendation is to start at the age of 25 years. And anyone who gets a negative result, meaning that there's no HPV that has been detected, screening interval now is a bit shorter. It's 3 years, every 3 years. Now, where HPV has been detected, we'll either do testing between where it is available, and the testing between is a cytology such as pap smear, which is the second screening modality available in the country, or where it is not available, and also depending on whether, based on the clinician's assessment, is this someone who's likely to be lost to follow-up, they may, at that point in time, intervene and do the different interventional treatment modalities that Dr. Odongo had highlighted earlier. Now, when it comes to the second testing modality for screening after HPV, the second one in terms of efficiency and efficacy is cytology. And cytology, which we commonly know as pap smear, has been the cornerstone of cervical cancer screening world over for a very long time. For the HIV negative population, where HPV is available, we will recommend that to those who are younger than the age of 30 years. And for those who are HIV positive, those who are younger than the age of 25 years. With cytology, we want to do the screening at 3-year intervals. For those who are HIV negative, HIV positive could range from 1 to 2 years, depending on the risk. Now, what about those areas where there is no HPV or cytology? The third modality available is what we call visual inspection with acetic acid. And this is what Dr. Odongo was saying, that we will use something similar to vinegar, apply it on the cervix, and inspect either with the eye or inspect with special cameras. That for a long time has been the mainstay of screening in our part of the world. But it has its challenges because it also requires supervision, and sometimes it may miss. Remember, there are those lesions that are microscopic, will not be visible with the naked eye. And then, of course, it will often tend to pick things downstream when the disease is already established, but we want to pick the disease much earlier upstream.
So what you'd advise is that for women in particular to start screening as early as 21 years. And for most of us, the most relatable form of screening that we know is the pap smear, or the one that you've mentioned, a cytologist test. And that actually reminds me, there was a couple of years back where there was a conversation of just how uncomfortable the pap smear test is. And that may affect even how often people get tested for HPV. Now, in your practice, Dr. Odongo, have you seen certain barriers to women getting screened? Is the pap smear test something that a lot of women are shy away from? Is there a possibility of maybe the future making the screening process a bit more palatable, for lack of a better word, to encourage more women to come in for screening?
Gynecological examination itself is not only a concern to women, but it's a potential cause for embarrassment, mainly because one has to introduce a foreign object. We many times introduce what we call a speculum. It is something like opens like a beak of a bird to try and expose the vaginal walls and the cervix. And those who have experienced it say it is not a very pleasant experience, mainly because maybe it's too cold or the doctors have not explained properly. And so one of the myths is that the speculum is very painful, but like we say, over time you learn how to have this communication passed over to the patients, because once you inform them that this is what I intend to do, take them step by step, it becomes kind of acceptable. But just to also state that maybe now we have made that a little bit better, the process of obtaining HPV specimen for examination. And I think, Dr. Ahome, I don't know that you carried a sample you can demonstrate that now the women don't have to go through a speculum examination. They can have these at the comfort of their homes, and the specimen is delivered to the laboratory using a special kind of self-collection kits that the women can now use to avoid this particular, the use of speculums.
I think that's a very interesting development, especially for women who have that barrier of going in for the pap smear test. Maybe you could elaborate on this self-collecting HPV test kits and how women can access it.
Absolutely. So there is device that allows one to collect their own sample and submit it to the laboratory. And that circumvents, and I have a kit here, which I'm going to demonstrate. This innovation was designed and came about to circumvent that issue of the hesitancy around the traditional healthcare provider collected sample. This device can be used by the healthcare provider, but it can also be used by the client herself. It can be used at the health facility or at the comfort of the home in the community. At Lancet, we have strategically selected the Everlean brush, and I'll take you through the brush and also explain why we selected these. So the color pink is not accidental. This brush was designed by women, for women. And essentially it comes as a pack. Once one has confirmed the expiry date, you'll open the pack by simply ripping off the cover. And in terms of packaging, it's very easy to remove from the packaging itself. It also comes with an instruction for use. And essentially, one needs to, of course, wash their hands first of all, open the kit, assume a similar position as one would assume when they're inserting a tampon, which would be one leg placed on a comfortable stool height. The kit comes with a cover. So cover is opened by just pressing, and it exposes these lead bit. So now one should not touch this aspect. So in terms of design, it has these lips. These lips allow a lady to know how far they should insert the brush. Once the lips make contact with the vulva, that's external genitalia or the labia, lady should then now push the plunger up. It will click as it has to let her know that she's pushed the plunger to the expected depth. Then after that, she'll just turn it 5 times. And with each turn, there's a click. I don't know that it's being captured by the camera. So after the 5th click, she then removes the device, and without touching the bristles, pulls the plunger to retrieve the bristles inside. It will click again to let her know that she's secured the bristles inside. After that, without again touching this part of the lip, cover, and again it clicks. So it comes with both, structurally, the lip to let her know how far she's pushed it in, and the clicking noises to let her know that she's actually performed the procedure or maneuver the right way. Once she's done that, just a matter of placing this back into the packaging. Again, clicks to let her know it's properly secured, places it in an envelope, and drops it off at any of our laboratory branches. And then now from there, that's when we undertake the PCR testing.
Okay, if you could inform our audiences that where they can get access to that, innovative tool, so they don't have to go in and maybe if they're embarrassed about the procedure, and a few more pointers, accessibility, product price, what have you, just a few pointers for them.
Right. So this can be obtained from any of our branches. So just a matter of walking to any of our branches with the doctor's prescription for screening test, ask for the brush, and they'll be provided this. So we don't sell the brush as a product. What we provide is a service, and the service is the HPV screening test. So in terms of the HPV screening test, we have a very competitive price. And we also have other partners we are working with whom we've negotiated a fantastic rate. So for anyone who wants additional information on these, feel free to visit our website, and we will provide more information on who our partners are. The other thing I wanted to point out with regard to this brush, seeing that there are no fluids or liquids, the main critical thing is just to keep it safe in a dry place. We normally recommend that after one has collected their sample, they drop it off to our lab within a week's duration. Turnaround time for the test, very short, within 3 working days. They will have
So they should submit
results.
it within a week of collection.
Preferably, but if one was to go and read about the studies, can stay as long as a month, but we don't want you to stay for as long as a month. The reason you're doing the tests is so that we have a result as soon as possible, so that we know whether to intervene and what intervention is needed. So I personally prefer to tell ladies, once you've collected your sample, please bring it as soon as possible and don't take too long.
And you'll have your results within a week as well.
And you'll have your result within a week.
Oh. Pamela, I think maybe during the time you went testing, if this was available, perhaps you would have caught it sooner. And I think this important discussion just brings us to the point where you have to create awareness about HPV, because you could be going around with this infection for as long as 30 years, as we mentioned, and we don't really know in how much danger that you are in. So what would you tell to women out there who are perhaps hesitant about going for screening and just how important it is?
From my own experience, after the treatment of cervical cancer, I saw it fit to go back to the society, make the women know that there's screening, and this screening can really save women's life, and we shouldn't lose any women due to cervical cancer. Why? Cervical cancer is a cancer that can be prevented. It can be deorganized before it much damage to the body, and when captured early, it's treatable. So I found out that a lot of women don't really know about cervical cancer and how it comes along. Maybe mostly we used to think that cancer is something that will feel pain, and so I told them, with my own experience, I had to make them understand that mostly there are no signs and symptoms of cervical cancer. So the best way for you to know if you have it and to be safe is to go for screening. And mostly screening is free. And as we see, a lot of bodies come in and they do the screening freely. And you can even get it free of charge from a government hospital. And so I really advise women to go for screening, because one, if it's captured at an early stage, again, you don't have to go through the harsh sessions of treatment like chemo, radio, and brachy. Also, it will be friendly on your pocket. If you go for chemo and for those other treatment options, you are going to use a lot of money, and also health-wise, it's very tough on the body depending on certain individuals. So it's better you go when it's captured early. You can be treated, like Dr. said, that those that you don't even have to go for surgery, they can do the cryo and you are safe from cancer. During the COVID session, I think when everyone was locked up, I came up and met with a group of cancer survivors through the Kilele Health, and that is where we had to learn about storytelling so that we can package our stories for better impact on the people. And that is where I got the skills of storytelling and advocacy and sensitization. And through that group, we took another step higher. We started going physical sessions for hiking and walking. And after the treatment, I've been able to go to Mount Kenya thrice, summiting. 2023, I went to Kilimanjaro, sensitization and raising funds for newly diagnosed women of cervical cancer. I'm a mother of girls. I have 2 girls. The HPV vaccine came in. I think it was 2019 that it really came in strongly. And I thought this is the best that I can give to my girls. So my girls, I took them for the HPV vaccination. And I'm really advocating for other women to take their children for the HPV vaccination, because we really have to kill this thing at the grassroots level, so that we have a generation, girls and women, that are free of the cancer, cervical cancer. And I also encourage women to go for the SHA, because if you have that card and you are found to be having the disease also, it will help you rather than staying at home. Because mostly, when we go for the screening, we'll get a woman, they have the disease, but then they will not have money that will make them go further for the other tests.
I think that's very inspiring advocacy stories from your end. And as they say, prevention is better than cure. Just to reiterate, register for SHA so that in case anything happens, you'll be able to have funding to address the issue. Daktari, maybe part in short call to action for women.
Yeah, we are part of the global movement and guided by the World Health Organization cancer elimination strategy by 2030, cervical cancer to be specific, whereby we have got the 90-70-90 strategy, which we are part of, whereby the first 90 means girls are vaccinated, 90% of the girls. Then the other 70 means we screen our women with a high performance test, in this case being HPV DNA screening, 70% by year 35 and also by the age 45. And of those who are found to have either malignant or pre-malignant disease, 90% of them should receive some form of care or should receive care. So we are plugged into the global vision or elimination strategy of the 90-70-90 strategy of the World Health Organization. Thank you.
Dr. Wahome.
For me, just to reiterate what has been said by my panelists here, just put a twist to it, that self-care is part of taking charge of one's health, and going for screening tests. One need not wait for the thematic month. We should take charge of our health care in a similar way we do take charge of, just to give a good example, brushing teeth every day in the morning, that's part of self-care. And for ladies who are eligible for HPV testing, and considering that this is the recommended high-performance test, even by the WHO or MOH, the Evelyn brush offers an avenue for self-care. So for any lady out there, grab one of these devices, speak to your healthcare provider, collect the sample at the convenience of your home, and drop it off at any Lancet laboratory close to you.
Thank you. Thank you all so much for joining us today. And that brings us to a wrap of our important and timely conversation on HPV awareness and cervical cancer awareness as well. So to the women out there, ladies out there, you heard it from the Daktaris. Go grab the Evelyn test kit, go get tested at your nearest health facility, and keep it velam.